Now, what I want to talk about in this video will apply to any clinical situation you might find yourself in, or indeed any first aid situation you might find yourself in. And it's about how we give priority to various aspects of care. Prioritization of care. And the principles we use here are A, B, C, D, and E, just the first 5 letters of the alphabet. Now why it so happens that these immensely useful clinical principles just fit into the first 5 letters of the alphabet, I've no idea, but they do. Let's start off with thinking about the first one, which is airway. Absolutely vital that the airway is patent. The airway has to be open so the air can go in and out. And very often we just assess this by talking to our patient. If the patient can talk to us, then by definition that means the airway is clear, because the vocal cords are in the airway. So if the vocal cords are vibrating, generating the patient's speech, then air is going through them and the patient has a patent airway, then we can move on. But other times we're not so sure. And in this situation we need to look, listen and feel. So we look for the patient of the movement of the patient's chest. We look for the movement of the patient's abdomen to see if we've got normal ventilatory movements. And if we're not sure, we can go closer. And what I normally do first is put my hand over the patient's mouth and nose, and it's very reassuring if you feel the patient exhaling on your hand. But if we're not sure, we can go closer. We can put our ear on or near the patient's nose, and we can look down over the line of the patient's chest and abdomen, and we can look for movements from that angle. And at the same time, if there's any breath, we can feel it on our ear, because the ear is very sensitive, and we can also hear it. If there's anything, if the air's going in and out, we can hear that with our ear. So we need to assess this, look, listen and feel. Because if the airway is blocked, the oxygen is not getting into the patient's body. They'll become severely hypoxic. And if the airway is fully blocked, they'll become unconscious within a few minutes. Shortly after that, they'll get brain damage and damage to the heart, particularly the heart muscle, the myocardium. And shortly after that, they're going to die. I mean, it's said that oxygen lack first stops the machinery, then wrecks the machine. So first it will stop the brain from working, but then it will go on and irrevocably damage the brain. Permanent brain damage will occur. We call it hypoxic brain injury. So vital that we keep the airway open. And in emergency situations, if the patient's hypoxic, then that's going to cause hypoxia of the myocardium, and that's going to make the myocardium more irritable, and it won't respond to our resuscitation attempts. It's sometimes said that blue hearts don't start. Which brings us on to another interesting point, cyanosis. Hypoxia will cause cyanosis, or hypoxemia will cause cyanosis. So hypoxemia is the lack of oxygen in the blood, and that's going to mean the blood becomes darker red. But the strange thing is, when this dark red blood is seen through human skin and human mucous membranes, it gives a blue tint. So cyanosis indicates low levels of oxygen as well, another important clinical observation. Now, if the patient's airway is not open, we need to open it, especially with a reduced level of consciousness. Now, what is the most common thing that blocks the airway in an unconscious patient? What is the most common cause of airway obstruction? Well, the most common cause of airway obstruction is the patient's own tongue. It falls back. So what we need to do is extend the neck, and that pulls the tongue forward, and that opens the airway. And normally that will open the airway. We reassess, we look, listen and feel, and hopefully we will then see the chest movements, feel the air on our hand or ear, and hear the patient breathing. That will restore it by opening the airway. Now, the exception to this is a patient with trauma of the upper chest, neck or head. If they're unconscious and can't talk to us, then we have to assume they have a cervical spine injury. And if we move the neck to extend it, we can move the broken vertebrae, and that can transect the spinal cord, and that can turn a serious injury into a catastrophic injury. This is just unthinkable. We never want this to happen. So in that case, we would use the jaw thrust manoeuvre. And here, the fingers go behind the angle of the patient's jaw, and you pull the jaw forward. So the patient's bottom teeth are sticking over the patient's top teeth, and that also pulls the tongue forward out of the way of the oropharynx. We can open the airway. And at this stage in the hospital situation, we would certainly give high concentrations of oxygen as soon as that was available. Now, people do worry about oxygen sometimes, but giving healthy people high concentrations of oxygen for short periods of time is absolutely safe. Now, I know some people are what we call carbon dioxide retainers, and they often can stop breathing if we give them too much oxygen, but it's important to remember these patients will still die through lack of oxygen the same as anyone else. So in emergency situations, we tend to just put high levels of oxygen on everyone. So that's A for airway. Moving on now to B for breathing. And of course, this is just an integral part of every clinical assessment, isn't it? We assess the rate of breathing, so we know the patient's respiratory rate. If it's too high, that's tachypnea. If it's too low, that's bradypnea. We want the rate to be between, we say, 12 and 20, we accept as normal. And we would also examine assess the rhythm of breathing. Is there a regular rhythm to the breathing? And at this stage, we can also take the patient's oxygen saturations on a finger or on her ear. If they're peripherally shut down, use a central point is often better. And we would assess their oxygen saturations, and we certainly want those to be above 94%. And we're also listening at this stage, so partial obstruction, for example, of the upper airway, we'll call what we call stridor, where we can hear the air going past an obstruction. Of course, if there's complete blockage of the airway, there's going to be no sounds at all, but we can hear this stridor sometimes, obstruction of the upper airway. Or if there is bronchoconstriction in the lower airways, that usually gives rise to a wheezy sound, so we can listen to that, and it gives us a lot of clinical information. We can also percuss the chest. We can listen with a stethoscope. And another quick test, especially in trauma, is just make sure that the trachea is central, because if the trachea is deviated, that can indicate pressure. So for example, if a patient had a tension pneumothorax after an injury on the right side of the chest, that would push the trachea across to the left, the tracheal deviation. Very quick and easy to test for. Now, in some clinical situations, we can improve the patient's breathing just by sitting them up. Patients breathe better when they're sitting up. In other, more emergency type situations, if the patient's not breathing, then we need to breathe for them. Now, normally the diaphragm goes down, the ribs and intercostal muscles goes up and out. That increases the volume of the chest, that reduces the pressure, and air is sucked in. We are negative pressure ventilators. But if a patient can't do that for themselves for some reason, then we can breathe for them by blowing air in. This is called positive pressure ventilation, intermittent positive pressure ventilation. And here in a hospital situation, we'd use a bag valve mask, and we'd probably use airway adjuncts. An airway adjunct is just anything that you use to help you with the airway. So we might use an oropharyngeal airway, or a nasal airway, or an eye gel, or possibly even endotracheal intubation. In first aid situations, you might just need to use mouth-to-mouth ventilation. But the principle is the same. We are using external pressure to blow air into the patient's lungs. So we have breathing. Now, if you say to a patient, are your A and B satisfactory? And they say, I don't know what you're talking about, then by definition that means that their A and B are okay, because as we've said, the vocal cords are in the airway and they're breathing to facilitate speech. So going on to C. C stands for circulation. And again, this is just intrinsic to all of our clinical observations and assessments. So what is the patient's heart rate? What is their pulse doing? And learn to palpate peripheral pulses. And also learn to palpate central pulses. Because if the patient is in an emergency situation and their blood pressure is low, then the peripheral pulses will go. So remember, when the blood pressure is low, the peripheral pulses go. So learn to palpate the carotid and the femoral pulses as well. Use your machines by all means, but there's no substitute for palpating the pulse. And of course do the patient's blood pressure. And test their capillary refill time as part of the assessment of circulation. So we press the fingernail beds for 5 seconds and we want them to go pink again in under 2 seconds. But sometimes if the patient's peripherally shut down, we can do what we call a central capillary refill time and do it on the... I normally press over the sternum and watch the capillaries reperfuse after 5 seconds of pressure. Heart rate, blood pressure. We can also assess the heart rhythm if we've got the relevant equipment with us at this stage. Now, D stands for disability. Now, if your nervous system's not working, that's going to cause disability. So D for disability is really about our assessment of the nervous system. And of course, there's many ways we can do this. But to start off with, we can use these principles of GAP, the GAP principles, to assess D for disability for nervous system. Now, G is for glucose, because if the patient's hypoglycemic, they'll be unconscious. Make no mistake, hypoglycemia causes unconsciousness and will cause death if we don't recognise it. So at this stage, we check for glucose. And AVPU is the patient alert? Are they responsive to voice? Are they responsive to pain, or are they unresponsive? That's the AVPU score. And that gives us a very rough indication of the patient's LOC, their level of consciousness. If more time was available, of course, we can do a full Glasgow Coma Scale assessment, looking for a normal level of consciousness of 15. And another quick and easy test is the pupils. Just shine a light in the pupils, and both equals should constrict briskly when we shine a light in them, and they should be completely equal. If they're not, then there could well be something going on inside the cranial cavity. For example, if there's a bleed in the right side of the cranial cavity, that can cause a dilated and sluggish right pupil. But do be careful, because a minority of people do have unequal pupils anyway for other reasons. And also at this stage we could test for lateralizing signs. So do the hands have equal power? Do the arms have equal power? Are the legs moving equally? To make sure that the motor function on both sides of the body is equal, because if it's not, that's what we call lateralizing signs. So for example, if there was an intracranial bleed on the right side, that could cause weakness in the left arm and the left leg. So that's D for disability. Exposure. Now, we certainly don't want to expose our patients all the time, but in a trauma situation especially, we need to inspect all of the patients all the surface of the patient's body. So do maintain their dignity, do get chaperoned if you feel that's appropriate, but the patient's whole body needs to be examined in exposure. And I've made up a couple of other things for E as well. Environment. So we need to maintain a private environment, certainly when the patient is being exposed. Patient dignity must be maintained at all times. It really is not negotiable. And also it's important to think about the temperature. For example, if a patient has internal bleeding and the environment is cold, the patient's body temperature can drop, and that will reduce the coagulability of the blood, because blood clots best at 37 degrees centigrade, because it's all based on enzymes. So when the body temperature is low, the blood will flow. We have to maintain adequate body temperature, adequate environment. So think about the environment, make it as comfortable and therapeutic as possible. And if you want, E can stand for everything else as well. We will go on to what we call the secondary survey. So this A, B, C, D, E really is what we call the primary survey. We can then go on to a much more detailed head-to-toe examination of the patient if that is appropriate. Now, treat life-threatening problems first before moving on to the next. So we assess the airway and we make sure the airway is patent before we go on to B. Then we make sure the patient's breathing adequately before we go on to C. So if interventions are needed to make sure the patient is breathing properly, we would do that before we go on to C. So these things are assessed and treated as we find them, in sequential order. It's not like we assess A, B, C, D and E and then go back and treat A. No, we assess A, then we treat A. We assess B, then we treat B. We assess C, then we treat C. The other things, I'm afraid, just have to wait. And of course, we need to assess the effects of the treatment. We do this in everyday life, don't we? We try something and we say, well, has that worked then? So we need to make sure that when we open the airway, it is opened. That when we are assessing, when we're treating the patient's breathing, that we are in fact ventilating the lungs effectively. We need to assess the effects of our treatment. If we've assessed C and we find the patient has no circulation, then we need to carry out chest compressions, but we need to assess that these are working properly as much as we can. So assess the effects of treatment. Now, we never need to keep clinical situations secret from our colleagues, especially in emergency situations. So as soon as we're unhappy, call for appropriate help early. Now, I've called for help on many occasions and often I've needed that help. But other times I've shouted for help and it turns out it wasn't such a big deal after all. I didn't really need that help. And likewise, many times people have said, can you help me please? And I've ran into a cubicle. And it turns out that sometimes they don't need help. It was just a bit of a false alarm. Well, that's absolutely fine. I'd rather be called 999 times when it was unnecessary than someone missed that one time when they really did need help. So feel free to take a second opinion, feel free to call for help anytime you are remotely uncertain. But certainly in emergency situations, call for help at the earlier stage. Anytime you're remotely uncertain, call for help. This is a team effort. Now, in trauma, the ATLS guidelines are slightly different, so, well, they're the same really, but we'll talk about airway with cervical spine control. So in trauma, rather than just saying airway, say airway with C-spine control. The two just go together. Breathing with ventilation, the two just go together again. And in trauma, circulation with hemorrhage control. So the hemorrhage control comes under C. But there is an exception to this. Now, military people, medical people, have been uncomfortable for some time with the ABC. And this was formalised in the Gulf War, First Gulf War in 1991, where these principles were agreed by the British military and all militaries. C, ABC is the priority. So sometimes C takes priority over A. And C stands for catastrophic hemorrhage. So if some soldiers might be walking along and one of them steps on a landmine and sustains a horrendous injury, a leg's blown off, just unimaginable levels of violence and trauma, but it happens. And there were healthy seconds before, so their airway breathing's okay. The problem is they've got catastrophic blood loss. So that would be addressed first, probably by arterial clamping, by tourniquets, by direct pressure. So in some situations, catastrophic hemorrhage is dealt with first, then we go on to airway breathing circulation. That's the only exception I can think of to the A, B, C, D, E priority of care if there's catastrophic hemorrhage. Complete an initial assessment and reassess regularly. So this is not a one-off process. It's not that we say, well, I've checked A, B, C, D, E, I'm now going for a cup of tea now. No. We need to constantly monitor and reassess. For example, we might assess that the patient's airway is patent in a patient with low levels of consciousness, but then they vomit, and then the airway is not patent. They can obstruct the airway by inhaling vomit, and they can get aspiration pneumonia. So we need to constantly reassess. Or a patient might be breathing satisfactorily at one stage, then they get a severe allergic reaction and bronchoconstriction, for example, and then of course they're not breathing. We need to constantly reassess this. It's not a one-off process. It's an ongoing assessment process. So we assess, we intervene, we reassess. An ongoing process. And as we reassess, we assess the effectiveness of our intervention. Now, of course, if you've got a team with you, that's wonderful. If we've got a trauma coming in the A&E situation, we'll have an airway person, a breathing person, a circulation person, and they've all got assigned roles, and that can all be done simultaneously if we're in a team situation. So that's nice, because A is still being dealt with immediately, but at the same time, people are simultaneously dealing with other problems in a severely traumatized patient. If we have a team, that's wonderful. Communicate effectively using the situation background assessment recommendations. Again, these were developed by the military. I think this was developed by the American Navy, but it works very well. So I might go to my consultant and say, the situation is Mr. Smith in cubicle 1 has gone into cardiac arrest. I think he's got ventricular fibrillation. The background is that he came in with chest pain, suspected myocardial infarction. I was just doing the 12 lead and he went into ventricular fibrillation. So my assessment is we're in a cardiac arrest situation, ventricular fibrillation. My recommendation is that basic life support is carried on and that advanced life support is indicated. Although of course the consultant should know that, but feel free to recommend it anyway. So no, it really works. This SBAR, if you go through that, it works and we get clear communication. There's been so many catastrophic things have gone wrong in healthcare through simple lack of communication. And this SBAR really does help. I think it's a great tool. So there we are, A, B, C, D and E. Now, having considered the primary survey, we want now to go on and think about the secondary survey. And this takes place when the primary survey has been completed and the patient is physiologically stable and we've already checked for A, B, C, D and E. And the secondary survey, although it was originally developed for trauma care, is actually equally applicable to all aspects of care: medical cases, surgical patients, trauma, and indeed it applies to first aid situations. So thinking about the secondary survey, and it needs to be ample. We need to do enough, it needs to be ample. This is where this idea came from. So the ample secondary survey as a tool for history taking was first developed by the Advanced Trauma Life Support Guidelines. But then people thought, well, it would be good to put an S in front of it. So they put an S in front of it, and we'll see what that stands for. So now we talk about a sample assessment. And this is really a mechanism for history taking, but it's a good one. So S for signs and symptoms. A for allergies. M for medications. P for past medical history. L for last oral consumption, last food or drink. And E for the events leading up to the incident or the environment in which the incident took place in. So let's think about these now. So first of all, we think about signs and symptoms. And we're getting this largely from the patient, if they're able to give us that information, or from the patient's family or other people that have come in with the patient, who know the patient, because we're trying to gather this essential historical information. So this is not so much our assessment of signs and symptoms, that will come later, This is the signs and symptoms as reported to us by the patient and their significant others. And this is remarkably important, that we know the signs and symptoms from other people. So, for example, a patient might come in with delirium. Now, when an older patient comes in with delirium, when I'm assessing them immediately in a first aid or A&E situation, it's very hard for me to tell if this patient has dementia or has an acute reversible delirium, because that will depend on knowing the patient. It would depend on knowing their history. So what I always ask relatives, is this normal for your dad? Is this normal for your brother? Is this normal for your mum? And you get an impression of what's normal for them. So the signs and symptoms that they've had in the past. Or a patient may have long-term diabetes or asthma, and the signs and symptoms again can be reported, what they are normally like, and crucially what has changed that has brought about seeking your attention. So in other words, is this an acute on chronic condition? So for example, a patient might have chronic obstructive airways disease that they've had for the last 20 years, but then they have an acute exacerbation and the symptoms become acutely worse. And we need that essential information from the significant others that come in with the patient. SA, allergies. Before we give any drug or any treatment, every single time we ask if the patient has any allergies. This is absolutely vital, because the principle is that we must do no harm. So we must gain this information. And this could also tell us if the patient is having an acute allergic reaction, such as an anaphylaxis. Now, practically, this can be a bit of a problem, because a lot of patients think allergies means any reaction to a medication. And of course we know it doesn't. We know that allergies are a particular type of adverse reaction to a medication. So patients will sometimes say they're allergic to a drug if it gave them a stomach ache or it gave them a bit of diarrhea. And sometimes we need to kind of tease out what is allergy and what is side effect, because it can sometimes be important to give a patient a particular drug. And if they're not allergic to it, we like to go ahead and give the drug. But we always check for allergies, so we ask the patient any allergies, and we ask the relatives or significant others with them as well, and of course we record that information. And if patients are allergic to things, we normally write that in red on their notes somewhere to avoid the possibility of that ever being given in error, which of course is quite unthinkable. Could potentially cause a systemic, potentially life-threatening reaction. SAM, medications. Of course, we need to know the medications that the patient is on. We need a full list of medications, and we need their doses of the medication. And the medications will also guide us as to what is wrong with the patient. It will also guide us as to their chronic conditions, if they have any. So for example, if they're on asthmatic medication, or if they're on diabetes medication or heart disease medication, that will indicate that that underlying condition is present. Or especially we want to know if there's been any changes in medication, because if the medication has changed, that could bring about the signs and symptoms, the clinical features which bring about the admission. It could be an iatrogenic problem as a result of medication taking or other medical problems. So we need to know about medications, absolutely vital. And we also need to think about toxins that the patient might have been exposed to. We can include that under medications. And in the A&E situation, it's absolutely vital to know if the patient is on blood thinners. Are they on any anticoagulant medication, rivaroxaban or warfarin or heparin? So for example, if a patient's had a head injury and they're on anticoagulants, then that makes the risk of intracranial hemorrhage so much greater. So we need to know what medication they're on, so we can account for possible side effects that the medication may start to have as a result of this acute condition or acute trauma that the patient has developed. So fundamental to know about medications. Past medical history, of course, we need to know the past medical history. And this can include things like the age of the patient, the size of the patient, the sex of the patient. All these things can have clinically significant things for us to think about. And then we want to know if there's any long-term conditions. Have they got diabetes mellitus? Have they got COPD? Have they got ischemic heart disease? Have they got a history of atrial fibrillation? Have they got a malignancy? Have they got a history of deep venous thrombosis? Have they got a psychiatric history? All of these things are essential for us to know about the past medical history. Some we get from the patient, others we get from significant others with the patient. And again, we have the possibility here of an acute on chronic condition. So someone may have diabetes but then develop acute hypoglycemia, or they may have diabetes but if they haven't been taking their insulin they might develop diabetic ketoacidosis. So if we saw the clinical features of diabetic ketoacidosis and we had a history of the patient taking insulin but reduced insulin doses lately, then that would very significantly aid our thinking and get us towards a diagnosis. And we also need to know the history of the present complaint. How has this happened recently? So we want the long-term history and we want the more acute history, acute and chronic history of the condition. Last oral intake. When did the patient last eat and when did they last drink? Now obviously in trauma this is of vital importance because there could be vomiting, and especially if the level of consciousness is reduced there could be aspiration as a result of that. If the patient's stomach is full, that gives us something extra to think about. But there again, if the patient's not eating, then that could explain part of their medical problem as well. They could be malnourished. Or if a patient's not been drinking, then that could again contribute to medical problems like dehydration. And of course, anaesthetist will certainly want to know this information prior to any possible sedation, whether it's for a medical, surgical, or a traumatic problem. So we need to know when they last ate or drank. And then the events and the environment leading up to the condition. So in trauma, we certainly want to know about the mechanism of injury. What happened? Did someone see it? Because the mechanism of injury tells us an awful lot about the potential injury that the patient has sustained. So was it a high energy trauma such as a road traffic accident or a gunshot or an explosion? Or was it a lower energy form of trauma, which again will give rise to possible other types of injury? Or was it sharp, penetrating injury? Or was it blunt injury? Because all these are associated with particular things that we need to look out for. And also thinking about, as well as the events, the environment. So was the patient in a cold environment? Had they been cold and wet, in which case they may be hypothermic, which would alter the clinical picture that we're seeing? Or have they been in an environment where they're exposed to a toxin or to chemicals? Or have they been in an environment such as a fire where they've been exposed to carbon monoxide and therefore may be suffering from thermal inhalation injuries and carbon monoxide poisoning? So all these aspects of history collecting are remarkably useful, and we need to collect these in a systematic way. SAMPLE. Now the second part of the secondary survey, the second part of the secondary survey is a head to toe examination. So sample is the history collecting part. The head to toe examination is your physical examination part. And this literally, as it said, it starts from the tip of the head and goes all the way down to the toes and everything in between. So we're assessing the head, the cranium, the facial bones, the neck, the vertebrae, the shoulders, the chest, the abdomen, the pelvis and the associated organs, the limbs, the long bones, the fingers. We are doing a full examination of the patient to get as much additional information as we can get. And this is where we look for signs and symptoms. The signs being something that we see, or we smell, or we feel, or we hear, something that we detect with our senses, and the symptoms being something that the patient complains of. So we've already got that from the relatives, now we get it first hand from the patient, and this gives us additional vital clinical information, all part of the secondary survey. So immediately follows A, B, C, D, E. This is when the secondary survey takes place. And it allows for standard operating procedures, SOP. and standard operating procedures and communication. Now what this means is that we can do the same thing every time. We have a way of doing it, and if you get into good habits when you're young, you'll keep those habits all of your life. We have a standard way of doing it. So we take the SAMPLE and then we do the head to toe examination in a systematic way. Then we don't forget anything. And that also allows us to communicate with our colleagues clearly. SAMPLE, head to toe. We can communicate clearly because we do it the same way every time. And you might think that gets boring, but it never does, because the patient's different every time. So although we're doing it the same way, it's reassuring for us. And then sometimes if you're having a busy day, you look back and you think, oh, I wonder if I did such and such. But then if you know that you did it in your standard way, using your standard operating procedure, doing it the same way every time, then your mind can be reassured that you did do it, because you always do it, and you always do it in that order, in that way. So this rapidly gathers history, crucial to the management of a new patient. The sample gathers the history, the physical examination gives us this additional information. This is fine to do. You can examine the patient any way you want, as long as you don't do any harm. You mustn't do any harm, so we wouldn't want to be destabilizing fractures or anything like that. And I'm sometimes rather reluctant to do full examinations, especially in the A&E department. So for example, if a patient comes in with appendicitis, I don't really want to test for rebound tenderness, because that hurts the patient, because the surgeons are going to come and test for rigidity and rebound tenderness anyway. That's guaranteed, they'll always do it. So sometimes we want to minimise the amount of times that painful procedures are carried out on an individual. But as long as we don't do any harm, collecting information is always good. The secondary survey is indicated in all trauma patients, so this is designed for trauma, but as we've said, so many medical applications as well. And the purpose of the secondary survey is to obtain a complete history, that's the sample, perform a head-to-toe physical examination, and reassess A, B, C, D, E. So part of the secondary survey is reassessing the primary survey to make sure that nothing in the primary survey has changed. If it has, we need to go back and we need to correct that first of all. So the secondary survey is carried out when the primary survey is completed, when resuscitative efforts are underway if we're in a critical situation, and when there's normalisation of vital functions. So this is always carried out, the secondary survey is always carried out on a physiologically stable patient, and it takes us more time, and we can take our time more with the secondary survey because we know that A, B, C, D, E are in place. And the secondary survey also includes a full neurological examination, including the Glasgow Coma Scale. And secondary survey, we can order required investigations. So the patient may be referred for an X-ray or for a CT scan. And certainly this is going to involve hematological blood, hematology and biochemical blood work, which we do on virtually every patient that comes in. So there we are. Secondary survey comes after the primary survey in two parts: sample, head-to-toe examination.